Today we are going to discuss about hypophosphatemia. Phosphate, the ion which gets least importance in the clinical rounds. What are the 5 points that we are going to see? What is it? What are all the causes of hypophosphatemia, levels, symptoms, and treatment? First, what is hypophosphatemia? As the name suggests, hypo is less, phosphate, the ion, emia is low level in the blood, low level of phosphate in the blood, value less than 2.5 milligram per deciliter. If we take phosphate per se, almost 80 to 85 percentage are in bone along with the calcium, forming the major ion in the skeleton. Second, it contributes to many important functions at the intracellular level. Only 1% is in the extracellular, that is in the blood. The ion that you are sending for the lab test, which is from the blood, is almost always indicate only the extracellular source which is present in the blood. So normal range is 2.5 to 4.5. Some text says 2.5 to 5.5 milligram per deciliter. Hypophosphatemia less than 2.5 milligram per deciliter in the blood. Second, causes of this condition. Almost always hypophosphatemia usually associated with other electrolyte abnormality. As you know, the ion which gets more clinical importance are most of the time the resident always focuses on sodium, potassium and calcium. Phosphorus, you can notice during your rounds also. Whenever there is a phosphate abnormality, you always find some other electrolytes are abnormal. That electrolytes obviously might be calcium. It might be orchestrated under endocrine connections. Obviously, other endocrine in the form of parathyroid or calcium, any abnormality might be connected it with. So if I have to put it short, the low phosphate in the blood can be broadly classified into two. One, genetic causes. Two is the acquired causes. In the acquired causes, it can be because of decreased intake, which is unlikely to happen because diet contains almost good amount of phosphate, or it might be because of the absorption, some parameter or something which is blocking the absorption, either for example alcohol or any other ions for that matter. We are not going into the details, just remember the broad category: decreased absorption or decreased intake. The phosphate is not reaching into the body at adequate level. The second and the most common clinically that we see is excessive loss. The patient is losing it excessively from the body, mostly through urine. Third, the shift inside the body itself, because we are measuring the extracellular component which is present in the blood. There are some kind of shift which happen which leads to these kind of low values in the blood. So causes at the beginning divided into genetic and acquired causes. In the acquired, decreased intake, which include decreased absorption also, loss or the shift. Under each category there are particular conditions, but as a whole I want to say phosphate unlikely to present as a particular entity unless it is a genetic cause. In most of the acute condition, you always able to catch the cause. If there is a malabsorption, if there is diabetic ketoacidosis, if there is any kind of refeeding syndrome, you will always catch. Even in the intensive care unit, if you see phosphate, you always notice at the end after seeing other blood markers or blood parameters. Suppose if the patient is having obviously particular parameter, for example diabetic ketoacidosis, for example after a long time patient is getting feed or refeeding syndrome, there will be clue with which you usually pick it up. Otherwise, calcium always tell the marker you have to look for and all. So regarding the cause, I already told. If you want in detail what are the particular condition which can cause it, yes, of course you can go through the text. I gave you an outline regarding the causes. Coming to the levels. What to say when it is severe, mild, moderate? What is the levels? As I told, less than 2.5 milligram per deciliter is hypophosphatemia. Less than 1 milligram per deciliter, which is very, very rare, is called as severe hypophosphatemia. 1 to 2 milligram, 1 milligram per deciliter to 2 milligram per deciliter can be called as a moderate one. More than 2 and less than 2.5 you can call it as mild one. The values as such it varies. It is not about the labeling or the terminology to say as mild, moderate or severe. It might be useful to solve a MCQ question, but it might not be that helpful in the clinical situation. A value of 2.1 and a value of 1.9 doesn't make much difference. Whether you label it as mild, whether you label it as moderate, don't worry, you are going to have the same approach because you have to treat it. So this mild, moderate, severe, less than 1, 1 to 2, 2 to 2.5. Sometimes 1 to 1.5 they say is moderate. Don't worry, nomenclature doesn't matter. First you have to manage, that is what going to matter clinically. Okay. So in this, one important entity I want to mention with respect to phosphate ion, rather than the level, it is the severity with which it developed makes the patient prone to the symptoms. Let me tell it again. Because clinically, most of the electrolytes, we treat it as per the value, the severity matches with the value. For example, sodium. More the lower level, more the symptoms. Similarly, potassium and calcium for that matter. Whereas in phosphate, the rapidity of the development of this hypophosphatemia decides the symptoms. It is rather than the values. Yes, values of course, but the rapidity plays a major role. So this is with respect to the levels. Coming to the fourth one, what are all the symptoms patient might have? At the mild level, unlikely patient will be having symptoms. At a moderate to severe level, the things that clinically we encountering are weakness, unexplained respiratory failure. Patient will have unexplained respiratory failure. You will be treating the respiratory failure as CO2 narcosis or some other condition. But if you notice, there will be subtle low phosphorus level which have to be replaced, otherwise patient will be having symptoms. Muscle weakness, rhabdomyolysis can occur if the hypophosphatemia occurred very severely at a short period of time. Muscle weakness, respiratory failure, sometimes cardiomyopathy, which are rare to appreciate because particularly it occurred only because of hypophosphatemia. No, most of the time it will be respiratory failure, muscle weakness and rhabdomyolysis, the common clinical symptoms. But here again, one more thing I want to put it here is phosphate or low phosphate level. If you, rather than treating the low level per se, if you treat the cause, usually it will resolve. This is one ion where even if sometimes you might not notice in the blood report, you might be treating a particular condition in the patient, it will be resolved. Hyperparathyroidism, if it is there, treat it, it will be resolved. If patient is reweeding syndrome, adjust it accordingly, it will be resolved. Alcoholism, decreased absorption, focus that which is interrupting its absorption, it will be resolved. Rather than focusing on the bringing the phosphorus to higher level, just focus on the cause. If it is the intracellular or extracellular shift, if it is because of the shift in the sense intracellular to the extracellular or extracellular to the intracellular, I am telling, you treat that condition which is causing that, it will be resolved. In severe form of hypophosphatemia, less than 1, mostly patient require treatment. So this is all regarding the symptoms, mostly related to the muscles. Treatment. Most of the medicine resident have doubt. They know the treatment of potassium, sodium, even calcium. One electrolyte which they might not get adequate exposure is phosphate. So whenever low phosphate is there, which is the preferred route, it is oral. Always select oral phosphate replacement. So what is the oral formulation available in the market? Sodium phosphate and potassium phosphate powders are available, tablets are available. You might require one tablet 2 times a day, yeah, 3 times a day. Dosing bit complicated than other electrolytes. As of now, you can remember dosing depends on the patient potassium level, sodium level also. Which formulation to select? Sodium phosphate or potassium phosphate, considering other electrolyte value. Probably you have to replace mostly orally. You can give with a natural source also if the patient is able to accept it. For example, a milk, you can advise them to take it a higher level. Chocolates, these are the things you can advise if there is mild to moderate symptom after ruling out the cause. Suppose if the patient is having severe symptom, phosphate is not at all getting corrected, what to do? IV formulation, intravenous formulation. In the intravenous formulation, again potassium phosphate and sodium phosphate are available. Which is the one we select? I use potassium phosphate. Depends on the patient overall other parameters, we give it as intravenous formulation. Probably 3 times a day might be required. And one more thing here I have to tell is regarding IV phosphate correction, there might be side effects with it. Calcium might go low, patient might develop arrhythmia. You have to be very careful. So while giving phosphate level, unless there are experienced staff, it is not an experienced center, better discuss with your seniors and start the IV phosphate. Don't go and jump and start IV phosphate. IV phosphate have its own side effects. You have to balance between risk and benefit. If the benefit is more, treat it. So that is regarding the treatment of hypophosphatemia. Oral is preferred. I hope you got a idea about hypophosphatemia. In summary, 5 things we have seen. First, what is it? Less than 2.5 milligram. Causes can be acquired or genetic. Under the acquired, 3 causes: decreased absorption or intake, increased loss or the cellular shift. Then levels we have seen: less than 1 milligram per deciliter is severe, 2 to 2.5 is mild, in between is moderate. Then we saw the symptoms. Last one is the treatment, oral or IV. IV preferably avoid, always select the oral. Out of all this, most important with respect to hypophosphatemia, evaluate for the cause. Which caused the hypophosphatemia? It will correct on its own. So that's all. Bye bye.